So I'm going to go over, this is a talk on subthreshold energy, and actually, I think SLT was probably the first subthreshold clinical treatment because we developed it with the idea of reducing photocoagulative damage. So I am going to actually discuss some of the basic science behind it, sort of review that for everyone to get up to date, up to speed. Just out of curiosity, how many people are doing SLT in the audience? Okay, reasonable number. How many people do SLT as primary therapy? Okay, fewer. All right. So one of my jobs is going to be to convince you to use SLT earlier and to use it as primary therapy. Now, actually, another question, how many people are doing MIGS, the MIGS procedures, various MIGS procedures, Glaucoma, iStent, CyPass? So, we're being bombarded by a variety of new MIGS procedures, but I don't want you to forget SLT is really a non-invasive surgical treatment for glaucoma. So really the concept, I think, is changing, and I think MIGS is helping us change this concept of what we've been doing, first medicines, then laser, then surgery. But, the MIGS are actually moving the paradigm forward so that we actually want to intervene earlier in the disease process. We want to reduce morbidity of progression. We want to ideally avoid trabeculectomies and glaucoma shunts. Reduce the need for more aggressive surgical treatment, of course, and also to reduce medication burden and the issues of compliance. And as I think everyone knows, in glaucoma, really one of the main problems that we have is compliance issues. So, as I said, SLT is really maybe one of the first subthreshold treatments. And my question actually, it's probably 20 years ago now, was, is it necessary to photocoagulate the trabecular meshwork in order to reduce intraocular pressure? So we know ALT argon laser trabeculoplasty causes thermal damage as a continuous wave laser. And the idea behind this whole session today is to get away from that type of technology. So my idea was, can we selectively target trabecular meshwork cells without causing any photocoagulative damage? And the idea was, of course, to use a short pulse laser to selectively target actually the melanin granule without causing any thermal damage. The laser that was ideal for this was a Q-switched frequency double neodymium YAG laser. And the idea was, again, to produce a biological effect without coagulation. I'm going to show this slide, which is on selective photothermolysis, which is actually somewhat the basis of SLT. And the idea is, again, to confine thermal energy. And that's what this whole session is actually going to be about, confining thermal energy. So what you need is three things, basically. One, an intracellular target. And the targets are primarily melanin, both in the trabecular meshwork as well as in the retina. Two, non-competing chromophores. And we're lucky in that both of these areas, well, at least in the trabecular meshwork, have non-competing chromophores, such as hemoglobin would be a competing chromophore. And then a short laser pulse to confine the heat energy. Now, I'm going to talk about a term called the thermal relaxation time of the tissue. And what we're actually targeting in SLT is the melanin granule. The thermal relaxation time of the melanin granule is about 1 microsecond. So if you use lasers, which are longer than 1 microsecond pulse duration, or maybe up to 5 microseconds, that there is thermal dissipation from the melanin granule or into the surrounding tissues. And for the cell, that's between basically 1 and 5 microseconds. If you're shorter than that pulse duration, then the energy remains within the target. So that was the whole idea behind SLT, and the idea of using short pulse durations, and we're using actually nanosecond pulses. So this is just showing the absorption curve also of melanin, hemoglobin, xanthophyll, and we can see that melanin is a very good absorber in the 532 range, 532 to say 600 nanometer range. It then drops off as you get to the longer wavelengths. So 532 is a high absorbing range, which is also why we're using green or yellow lasers, both in the trabecular meshwork and in the retina, because the absorption of melanin is quite high. So idea was, again, we can put these TM cells and feed them melanin. Then we irradiate them, and we can selectively target the pigmented trabecular meshwork cells, leaving non-pigmented cells unaffected. And as I said briefly, that we're actually targeting the melanin granule, and this is electron microscopy of a TM cell, and this is actually what we're targeting. So there's no thermal dissipation outside the TM cell itself. Again, and what we can do is an assay using fluorescent dyes showing which cells are targeted, and as you can see here, only the cells with pigment are targeted, and the adjacent cells that have no pigment are not targeted. Now, with argon laser trabeculoplasty, and we can talk a little bit about threshold a little bit, is that with argon laser trabeculoplasty, we know that that's a long pulse duration. It's a continuous wave laser. So energy is we're using pulse durations of about 0.1 second or 100 milliseconds or so. And with this, all the cells are effectively targeted at threshold. If you go above threshold, actually the cells are just vaporized right off the plate. They're boiled right off the plate. Again, with SLT, you're not seeing that because we're way below the thermal relaxation time of the tissue. So we can selectively target the cells. This was actually Rob Nowacker's work, and he's here, but he showed in human organ culture that, again, there's no thermal damage to the trabecular meshwork on electron microscopy versus argon laser, which there is. And I think this is actually becoming more important, especially for those of us who are doing MIGS, because I think actually argon lasers, in my opinion, is relatively contraindicated if you're planning on doing a MIGS procedure, because argon laser causes a scarring of the inner and outer wall of Schlemm's canal, so it's scarring the trabecular meshwork. And now we would like to have the trabecular meshwork canal, open and accessible to these newer MIGS procedures. So my recommendation is to avoid argon laser trabeculoplasty, especially if you're planning on doing these MIGS procedures. And then just as a photomicrograph from George Alvarado showing selective targeting of the pigmented cells within this is actually human trabecular meshwork, and showing that the the trabecular structure remains intact without any photocoagulative damage. Just a little bit about MICROPULSE diode laser, and some of you have heard about it. I'm not going to go into all the details because I think the other speakers will talk about it, but the idea is to basically reduce the thermal relaxation time, or reduce the laser pulse duration, so it's sort of closer and a shorter coagulative time. But what they use is a 0.3 millisecond on time and a 1.7 millisecond off time, which gives you a duty cycle. But basically, you're still in a thermal regime. So even 300 microsecond pulse duration, you have to realize, is still 300 times the thermal relaxation time of melanin. So when to consider SLT? Again, we're using SLT as primary therapy. And most people actually in the United States who've adopted SLT are using it as primary therapy now. We actually use it before prostaglandin. So I know all of us pick up the bottle of prostaglandin, and we've been taught that we should be using prostaglandins as primary therapy. But I'm going to try to convince you that maybe that's not the best idea. I think, of course, compliance is an issue. Patients with significant IOP fluctuation, I think, is valuable, and I'm going to go over some of those. That data, of course, visual field progression, even with controlled intraocular pressures, patients with low tension glaucoma, again, MIGS surgery, and even chronic angle closure, SLT is useful, as well as all the various types of glaucoma, PXF pigmentary, pseudophakia, steroid-induced glaucoma. We've used it, failed trabeculectomy. We've used it even after failed MIGS procedures, and these others, aphakia and regressed neovascular glaucoma with open angle. So why choose SLT, actually, over prostaglandins? So as I said, most of us choose the prostaglandins as primary therapy, But I'm going to ask you to actually hold that bottle of prostaglandin before treating the patient. And I'm going to give you the data, I think, and some of the data actually came from England, some of the first data from Dr. Nagar and her co-workers. So why use it? Well, I think, one, from my point of view, the most important thing is to keep the patient's pressure controlled and not depend on them to control it, because we know compliance is a very big problem. So I like to simplify their treatment as much as possible. And of course, glaucoma medications have all these problems. I think long-term, the use of the medications have been shown to cause conjunctival changes, which make it more difficult for us to do glaucoma surgery later, et cetera. And basically, the SLT gives you, effectively 100% compliance. Also, I think it's important, based even on the EMGT study, that as we know that, and these were sort of early onset glaucoma patients, 25% decrease in IOP, reduced the risk of progression by 50% in those patients. But I think even more importantly, that 1 millimeter, the risk of progression decreased 10% for each millimeter of IOP reduction from baseline. So of course, we want to keep our pressures as low as possible. So a few of the studies looking at SLT as primary therapy. And actually, Dr. Nagar and co-worker did some of the first work looking at this, comparing SLT and looking at the dose response, 90, 180, 360-degree treatment versus latanoprost as primary therapy. And, she nicely showed that is what you would expect, that latanoprost has a 90% responder rate at 20% IOP and about a 78% responder rate at 30%. There is a dose response to SLT. And what she found, and what we actually ended up using for our further studies with 360 degrees of treatment of SLT, was effectively equivalent to latanoprost as primary therapy with similar or not statistically significant responder rates. So that's why I would like to say that 360 degrees of SLT is effectively equivalent to giving a patient a drop of latanoprost. So we did the SLT med study, which was a multi-center clinical trial, looking at SLT as primary therapy, comparing it to prostaglandin. In this case, I think it was latanoprost as primary therapy. Followed these patients for a year and showed that SLT as primary therapy was statistically equivalent to medical therapy. And actually, when we tried stepping, if you needed a lower pressure, the stepped group was actually statistically lower than the medication group. So again, showing that SLT was at least as effective as the prostaglandins in this study. And there's been another study by McGilrath, similarly looking at SLT again as primary therapy versus prostaglandin, showing similar IOP reductions over a 12-month period, and also similar responder rates at 20% IOP reduction and 30% IOP reduction. So showing again that it's roughly equivalent. And then this study I thought was kind of interesting. This was a group of patients who actually had primary angle closure, but at least 180 degrees of the TM was open. And it was a prospective randomized study actually, and they treated the open angle with SLT 180 degrees. They compared it to a group of patients with prostaglandin and found no difference between the SLT and prostaglandin in percent IOP reduction. Again, demonstrating the sort of efficacy of SLT compared to prostaglandins. Now looking at the number of medications. So if patients are already on medications, I think the responder rate to SLT is lower. So, and this is what this study shows. This was a group on maximum tolerated medical therapy, and to look at the treatment outcome, and success was associated with POAG was better than the group of PXF. But basically, the lower the number of preoperative medications, the higher the success rate of the laser. Their overall success rate was about 45% on multiple medications. The success rate, I think, is primary therapy, as you saw, was probably in the 85 to 90% when you're using it as primary therapy. So your success rate is going to be much higher. Again, it's easy to perform. It's an in-office procedure. And as pointed out, there's no scarring of the trabecular meshwork. So again, we can use this prior to MIGS to MIGS procedures. This is the Quantel laser that we're using, the Optimus Fusion, which is an SLT and a combination SLT YAG. It's a very nice laser for this and very useful in the office. Now, this is actually a new lens that we developed, and I don't know if they have this here, but it's made by Ocular Instruments. I actually have a slight financial interest in this as well. But we designed this lens with these 5 bars just to show you, and it's actually a good tool for teaching the residents as well how to do gonioscopy and actually how to actually do a laser trabeculoplasty. Because each bar is 400 microns, and each space in between is 400 microns, so you can get 10 spots. And I'll show you a video, if you could play that video. So you basically are treating with the SLT laser. It's a 400 micron spot, and you treat your 10 spots or so. Then you click it, and it tells you basically where to position the next 10 spots. Because as those of you who know who've done SLT, that not all the time can you see where there's a reaction. There's no sort of coagulative burn that you see as you do with ALT. So sort of nuts and bolts of clinical application. I think we found that 360 degrees provides the best results. Basically, we titrate the energy to the TM pigmentation. So if it's a heavily pigmented TM, I start with about 0.6 millijoules. If it's lightly pigmented, I go to 0.8, 0.9. On average, I start with about 0.7 to 0.8 millijoules. You like to see these small microcavitation bubbles. And I think it's important that you actually keep the laser aiming beam down when you're actually doing the procedure, because you actually want to see these micro bubbles. But you don't have to see them with every spot. And then post-operatively, there's been a variety of discussion, but really some people actually use nothing post-operatively. As you know, with most laser procedures, you're using topical steroid. Actually, we don't think topical steroid is advantageous in SLT because we actually want to see a macrophage response, a slight inflammatory response. I use a topical NSAID a couple of times for the days of the surgery, the next day and the day after. So really minimal, and these patients do actually very well with minimal postoperative treatment. This just shows the number of studies, basically showing that most studies show that the laser gives you about a 20 to 25% IOP reduction. So what is the strongest predictor of success? Well, still I think its baseline IOP is correlated with the percent IOP reduction. Again, a study that was looking at the percent IOP reduction at various preoperative levels. So again, we're looking at around 22 to 25 millimeters of mercury, 26 to 30 millimeters of mercury, that this gives you about a 22 to 30% IOP reduction. I don't actually like to treat patients with SLT with the high pressures in the high, above 40 millimeters of mercury, so I like to actually put those patients on a medication and get them at least into the 30 millimeter range before treating them with SLT. Again, going back to the effect of medications on the SLT response and looking at aqueous suppressants versus prostaglandins, and actually this was a very small study, sort of a pilot study, but it sort of demonstrates what I'm trying to say, in that we looked at patients who weren't responding to SLT. Why aren't they responding? And we found that if we looked at those patients who were just on aqueous suppressants versus just on prostaglandins, you can see that those patients on the aqueous suppressants had an 87% response rate versus the prostaglandins, which was half, about a 47% responder rate. If their IOP was over 21, it was actually 156. If it was less than 21, it was 66 and 33. But basically, your responder rate was significantly higher if the patient was not on a prostaglandin as primary therapy, as a therapy. And this was also shown with this study, a predictive SLT response. Similarly, patients had a prostaglandin when used. They had a roughly 2 millimeter IOP reduction, no prostaglandin used. It was a 5 millimeter IOP reduction. So statistically greater if they were not previously treated with a prostaglandin. So again, think of SLT as an outflow treatment. It actually basically acts like a prostaglandin. And I'm going to show you some slides from Alvarado that basically he suggests that the two actually share a similar mechanism. And he irradiated the Schlemm's canal cells and looked at them and also been incubated with prostaglandin. He looked at their tight junctions and both caused the linearization of the tight junctions and improvement in their permeability of the canal cells. And when using, for instance, dorzolamide or timolol, there was no change in the electrical conductivity. So he suggests that basically the SLT and the prostaglandins are utilizing a similar mechanism, causing a secretion of cytokines, causing a change in the linearization of these tight junctions and improving the outflow facility. So again, suggesting that the two are working in a very similar manner. So I'd like to just reinforce that, again, thinking of SLT as an outflow medication, we want to lower the pressure. We want to think of complementary mechanisms of action. So actually my choice is, again, not to start patients on prostaglandin and do the laser. And then if I want to actually get lower pressures, I'm going to add inflow medications such as timolol or the carbonic anhydrous inhibitors or COSAP or Combigan. And my last choice is actually to use the prostaglandin. Is it repeatable? So just in a nutshell, I think people ask this question. If patients had a successful SLT the first time, there's a high probability of successful repeat treatment. Usually those patients which last for at least 6 months to a year, and there's been a number of studies. There was a study by Francis and co-worker. This is another study by Tony Riolini and Polat looking at the repeatability of selective laser trabeculoplasty. These patients at least had the first SLT effective for 6 months. Kaplan-Meier, this is the change in pressure, and you can see actually the second laser, they actually did better. They actually had a better pressure lowering than the first laser, and their survival rate actually improved from 590 days to about 1,054 days, which is interesting. And likewise, in this study, repeatability of primary SLT, again, the initial group, and then they were repeated, and they also had a longer survival than the primary SLT. IOP fluctuations, I think, especially in patients with severe cupping, as we know in the AEGIS study, that group of patients had more severe open-angle glaucoma, and what that study showed was that reduction of what they looked for was intervisit IOP fluctuations. And they found that if there was significant progression of visual field loss, if the IOP fluctuation from visit to visit was actually greater than 3 millimeters of mercury, standard deviation from the mean. So visual field progression increased 30% with each millimeter increase in IOP fluctuation from visit to visit. So that, I think, points to the fact that IOP fluctuation, at least in my opinion, is quite important, especially in patients with more severe cupping. It's probably not as important in patients with mild glaucoma, but with those patients with severe glaucoma, I do think it's more important. We looked at patients with SLT as primary therapy. This is a pure laser study. These patients never saw any medications. They were treated with 180 and 360. They were followed for 2 years. They had no additional medicines or treatment. We found, again, that 180 treatment reduced their intraocular pressure 28%. Actually, 360-degree reduced their intraocular pressure on average about 35% in the study. But for looking at their IOP fluctuations of less than 3 millimeters of mercury, it wasn't statistically different, 180 versus 360. But actually, if you look at actually 2 millimeters of mercury, in other words, you didn't want their IOP to fluctuate more than 2 millimeters from visit to visit. 360 was actually statistically better than 180 treating those patients. So it did reduce their IOP fluctuation to at least less than 3 millimeters and even 2 millimeters at 360 degrees. It's useful in low-tension glaucoma as well, and this was a large prospective study of SLT and NTG, 83 eyes, 46 patients. They had 360 degrees of treatment. They wanted a target IOP of 30% IOP reduction, absolute success, qualified success. And basically, they found that they achieved an additional 20% IOP reduction with 27% less meds at 6 months, maintaining this 30% total IOP reduction. And this is the triggerfish. I don't know if any of you have used this. The Sensimed triggerfish, which is a sort of a contact lens. It doesn't really measure absolute pressure, but it gives you a 24-hour pressure curve. They looked at these patients with normal tension glaucoma. And the bottom line is that although the pressures didn't change substantially, 13.5 to 11.3 postoperatively, so still 2 millimeters of mercury, that the biggest change was actually at night, that there was a significant reduction of the IOP during the nocturnal hours, even though the waking hours were roughly the same intraocular pressure. So I think that that's important. And of course, we aren't measuring the pressures at night, but sometimes we wonder why are these patients progressing with normal, quote-unquote, normal pressures. I think part of that is that they're having pressure spikes, pressure rises during the evening. This is, since we're talking about subthreshold in this session, this was intraocular pressure lowering with potential of subthreshold SLT. So what's subthreshold SLT? Well, I don't know, I don't like really this term for SLT, but what they did was they took conventional SLT and they defined subthreshold as two-thirds of the conventional energy. With SLT, it's actually a Gaussian curve. It's a statistical process when you're actually treating these patients. So if you use a higher energy, your probability of targeting more cells is higher. If you're using lower energy, the probability of targeting is lower. But what they did find was that basically there was really the efficacy of subthreshold SLT was comparable to conventional SLT. So in conventional SLT, we see these microbubbles. Subthreshold SLT, you're using, supposedly you're below this quote-unquote bubbles level, but you're still getting targeting. And I assure you that, yes, these energy levels that we're using are really actually all above threshold. So this is still, even though they're calling it subthreshold, it's still actually threshold, and you're actually doing quite effective selective targeting of the cells. Gandolfi also presented this using low-power annual SLT, which I thought was interesting, whether the patient needed the laser or not. In other words, these patients, it was a retrospective study, but he treated them with low power, 0.4 millijoules, 50 to 60 spots, and they compared them to their standard SLT of 360 degrees of treatment, 70 to 80 spots, followed them for quite a long period of time. And what was interesting that the patients with low-power SLT, more of them did not need glaucoma medicines, and the mean time to initiation of medications was significantly longer with the low-power SLT, suggesting that you're sort of repriming the meshwork every year. So every year he does a little SLT, sort of reprimes the meshwork, and keeps the pressure down. So I thought that was good. More recently, this isn't out yet, but Dr. Belkin in Israel is working on actually a transscleral selective SLT laser trabeculoplasty, with the eye with the purpose of being able to do the procedure in a single sort of session without an ophthalmologist potentially, that they can put this on the eye and basically do one session externally. So we'll see how that works. Right at the moment, my feeling is it's not going to be as effective as conventional SLT. They got a 20.8% drop versus a 33% drop with conventional. But it does suggest you can do it externally. Just a note about pigmentary glaucoma. And it is effective treatment for pigmentary glaucoma, but you do need to use much lower pulse energies. You don't want to see cavitation bubbles with SLT with pigmentary glaucoma, because you can get a significant pressure spike. As I indicated at the beginning, when you're actually targeting the melanin granule with pigmentary, of course, you can see there's, as we know, there's lots of melanin, both intracellular melanin plus extracellular melanin. It's everywhere. So you're targeting it. You're actually blowing these melanin granules apart, and they can actually clog the meshwork up and overload the meshwork. So you have to be careful. This just shows that there's a sort of a higher failure rate with pigmentary. They need to be sort of retreated. More often, I actually only treat one half the angle and then go back and retreat the other half in the future as needed. And then a little point about racial differences. So there's been a couple of studies looking at SLT in a variety of different settings. The West Indies, so there's a West Indies SLT. This group looked at Africans versus Indians, and they found actually significantly better response rate in the Africans than the Indians. So this shows that 20% IOP reduction here, and then the non-responders above. You can see that there's really a pretty good responder rate in the Africans and less so in the Indians, and I really have no explanation for that, but that's what they found. So overall, it's a low complication rate. There's, of course, no systemic side effects. You can get IOP spikes, usually 1 to 2 hours. We usually pre-treat these patients with iopidine. Iritis you get, but usually resolves spontaneously. There have been these rare cases of corneal edema, which the etiology is really not quite known yet. And then with pigmentary, of course, use lower energies. So I think it's really a viable first-line therapy. I actually offer this to my patients. I basically say they can have an in-office procedure with an 85 to 90% success rate without medicines, and they don't have to pay for the medicines. They don't have to take the medicines. And most of the patients, actually, it's the way you present it, I think, but most of the patients now choose SLT as primary therapy. So my take-home is really simplify your management. I think treat earlier, use it as primary therapy. And, this is just one other point, this early info that SLT may have a predictive response actually for your MIGS procedures. Thank you very much.
So any questions?
Any questions? Any questions?
Can I, oh, there's a question over there.
Yeah.
Some patients respond well than others. Why? Can you tell me?
Why do some patients respond? So that's I guess the million-dollar question. It's like medications. Some patients respond to medications better than they respond. One group of patients responding better than others. So I think it's really the extent of damage to the meshwork and the reserve. So I always think of the trabecular meshwork has a sort of potential, and if you're scarred, you're way down the line, then none of these procedures are going to be that effective. SLT or even medications, especially outflow medications. So you may be able to get the pressure down with an inflow medication, but you may not be, your outflow medications may not work as well because there's just not much to, for the aqueous to get through. So I think it's all, what the status of the patient is. Plus, it's a question of what's happening with the cytokines and what your sort of, your microbiology is or molecular biology of the meshwork is, what it's able to secrete, and what its reserve is there. So I think, there's a lot of issues of why people respond differently.
Do you think the amount of bubbles coming out plays a role in that? The
Amount of what?
of bubbles coming.
Well, I think too many bubbles is probably not good. Okay, it's not good because you're effectively you're actually probably destroying some of the trabecular meshwork because it's a acoustic effect. So I do think, though, that there is a dose response as you saw. So if you if you undertreat, you will get less of a response. You will get less of an IOP effect, and your duration of effect will also be shorter. We didn't really discuss that, but I think those people who've had 360 degrees there versus 180, not only is the magnitude of IOP response better, but the duration of the response is also better.
Thank you.